So let me just briefly interject. First of all, to thank all of you who presented so many cases. We presented, I think, more than 3,000 cases from general oncologists since the pandemic began. And just the fact that you're willing to share your practices and your thoughts, in that situation we're so grateful for that. And the other thing is, and I can tell you, all the investigators I talk to admire you all so much for what you're trying to do, keeping up to date. I mean, they have enough trouble keeping up with their own stuff. But when we talk about you all, they have nothing but admiration. And I think, what you're saying here tonight is a demonstration of that and what I've been hearing for my entire. So Swati, I'd like you to respond to this other common clinical question that comes up, which is the use of TKIs. Remember those in HCC? Both in patients with contraindication. Some of these patients have had liver transplants or, prior history of autoimmune disease. You may not want to even start with immunotherapy. So I asked her about how she approaches those patients. In patients with relative or really absolute contraindications to IOs, how do you sequence the TKIs?
I generally think of lenvatinib and sorafenib. I think they're both good options. Lenvatinib is generally a therapy that I often will go to because of the higher response rate and the encouraging data also that just came out of the frontline study of lenvatinib pembro versus lenvatinib. The overall survival with lenvatinib was impressive.
What's the initial dose that you use of lenvatinib?
I tend to use 12 milligrams in patients who are more than 60 kgs. I tend to use 8 milligrams in people that are less than 60 kgs. If someone is a little older and frailer, even if they're more than 60 kgs, I might start with 8.
And can you talk a little bit about how you approach second and third line therapy in patients who get either atezo-bev or tremelimumab?
I'll often think about using either lenvatinib or sorafenib. I think it's also very reasonable to consider using cabozantinib or using ipi-nivo in that setting. I think all 4 of those are reasonable regimens. The jury's not out yet on which one of these might be the most effective after atezo-bev.
So Swati, any thoughts about TKIs? Questions you have about that? What do you think about what she said? I was mentioning that we're going to the SGO meetings, and it's interesting. You hear about lenvatinib pembro there in endometrial cancer and their issues about how they dose, and then you come over here and you hear about it in HCC. Any thoughts about TKIs in general and specifically these scenarios?
So in terms of sequencing, I mean, it's still a data-free zone. Most of these agents were studied post-progression on sorafenib. And now that we're using, if you're, using atezo-bev, it's really, if you look at the NCCN, you have everything listed. But I think if I have to think through the options, first line, if the patient is not a candidate for immunotherapy, I would be thinking about lenvatinib based on impressive OS data that came out of the lenva pembro data that Dr. Goyal was mentioning. I think the OS was 19 months with lenvatinib, which is extremely, I think, amazing. So that would be my first go-to if a patient has contraindications to immunotherapy. And after lenvatinib, I would be thinking about cabozantinib because it has a slightly different mechanism of action. It hits, I think, c-MET and AXL, which is different from the other TKIs from my review. So I would be thinking of cabozantinib. And then if the AFP is more than 100, you also have ramucirumab as an option. In terms of nivo-ipi, that would be my last option if I've exhausted everything, and if the patients have had prior IO, they've progressed and not responding to TKIs, then maybe I would reach to the nivo-ipi regimen based on the melanoma world. We've seen that after single PD-1, we can get responses with PD-1 CTLA-4 combination. So that would be the way I would be thinking through.
So let's chat a little bit about biliary tract cancers. And Neil, thank you so much for joining us tonight.
Thank you.
Thanks to Dr. Goyal and Dr. Wainberg for working with us on this program. I feel good about it. I don't know. I'm curious to see, particularly if anybody